Hello and welcome to episode 8 of Opt to Thrive. What everyone needs to know about contraception around menopause.
Welcome to Opt to Thrive, your go-to podcast for women's wellness in midlife, designed to educate, support, and inspire you to live your very best life. And now your host, Dr. Karina Sims.
I hope you're having a great day today. Wow, winter has definitely been here. We are getting some pretty cold days, although the other day we had a couple of really spring-like days. It was like 21 degrees, I think, one day. It was spectacular. I'm not a huge fan of winter. I am envying those of you on the other side of the planet having your beautiful summer at the moment. Hope you are all enjoying those beautiful summer days. Soon that's going to be us, and then, well, you guys probably have a lot rougher winters in a lot of places where you are than we do here. So I really can't complain. It has been reasonably tame this year. We've been doing a lot of workout in the garden. There's a lot of things that we're kind of moving and clearing, and we're moving some big plants, digging them up from one place and putting them in another. We just bought the farmhouse over a year ago, and we're just still kind of making it ours. My son's going to have his 21st coming up in the next couple of months, and we really want to have a beautiful garden party for him, which is really exciting. So I've had a few questions lately around contraception and menopause, so I thought that I would address this topic today. The best stats I could find were that after the age of 40, a woman has less than a 5% chance of getting pregnant naturally. And by the age of 50, it's close to 0. But I didn't say 0. It is not 0. If a woman does conceive after the age of 45, remember her eggs are also 45 plus. And the chances that that egg is going to be genetically abnormal are more than 80 to 90%. So the pregnancy would very likely be genetically abnormal and either end in a miscarriage or present the woman with a very difficult decision to face in terms of keeping the pregnancy, depending on her personal views. But continuing on with a pregnancy after the age of 45 has its own set of risks and complications. So as I said, the chances are close to 0, but they are definitely not 0. In 2011, a woman from the Gold Coast fell pregnant and delivered her very first baby at the age of 50. That was all natural conception. She was married in 2010 and apparently was told her chances of naturally conceiving a baby were minimal. So that when she went to the doctor complaining of fatigue and hadn't had a period, she was told she was going through menopause. So when she saw 2 lines on that pregnancy test, she was shocked initially, but then delighted. And miracle of miracles, she delivered a healthy baby boy at 50 years old at 34 weeks gestation. For many women, though myself included, there would be absolute devastation if I were to find out that I was pregnant at this stage. I'm irritable, I'm tired, and I have a newly empty nest. The last thing I want is to start all over again in terms of raising another little person and all the things that go with that. So as a GP, I do everything that I can to help a woman avoid being in this predicament. And that is why discussing contraception is absolutely, positively mandatory until a woman is absolutely, positively postmenopausal. So let's dive in, shall we? I'm going to start by adding a quick caveat to what I just said. Now remember, postmenopausal means 12 months, no period, provided you don't have a Mirena or some other reason not to have a period. The caveat here, though, in terms of contraception, is that if a woman stops having periods before the age of 50, the recommendation is that she use some type of contraception for 2 years after her last period. Back when I went through medical school, we were taught that once a woman hits 40, she's too old to be on the pill. There was a time if a woman came into my office looking for a repeat pill script or just looking for a pill script, I would be having a stern discussion about the risks and encouraging her to consider progesterone-only options. So when I say the pill, I'm referring to the combined oral contraceptive pill. So this brings me to the first point I need to make, the difference between the pill and menopause hormone treatment. Okay, let's start with the pill. When a woman takes the pill, the hormones kind of override or take charge of her normal menstrual cycle. I like to say it hijacks the menstrual cycle. So it's kind of a fake cycle. Every 3 weeks, she's got a week of sugar tablets. During that week, she has what's considered to be a period. It's not really a period, it's actually just a withdrawal bleed. She's not having the hormones during that week, and so her body withdraws, and so she gets some bleeding. The pill works mainly by inhibiting ovulations, meaning it doesn't allow the body to release an egg to be fertilized. Now, menopause hormone treatment doesn't inhibit ovulation. So if a woman is still having a period, even if those periods are irregular and months apart, it's possible that she could still be ovulating, which means it's possible that she could still become pregnant. So one difference is that the pill inhibits ovulation and menopause hormone treatment doesn't inhibit ovulation. The reason for that is found in the potency of the hormones. So they both have estrogen and progesterone in them, but the estrogen and progesterone in the pill are much more potent than those found in menopause hormone treatment. As they have to be, right? To be able to override a woman's natural cycle, they have to be pretty potent. And this leads me to the reason 20 years ago that we were trying to get women off of the pill at 40. It was due to this high potency of the pill. This has changed though, and I can tell you that not everyone's gotten their head around this change, including some gynecologists. It's now agreed that if a woman is low risk for blood clots and heart disease, so she's not obese, a smoker, doesn't have a history of previous blood clots, stroke, or have known cardiovascular disease or other high risk factors for heart disease like high cholesterol and high blood pressure that isn't treated, then the current guidelines state that she could be offered a low dose pill until the age of 50. So she can go on the contraceptive pill until the age of 50, but a low dose one. So there are a couple that we generally use in this situation. Now 50 is considered the cutoff because age becomes a risk factor in itself, and because as our levels of estrogen start to decline during that perimenopausal period, our risk of heart disease starts to go up. The estrogen isn't there to protect us like it was. Okay, so if you're still having periods, you haven't had your tubes tied, and you have a male partner who's still fertile, then you need to be considering contraceptive options. We've talked about the low dose pill as an option for those under 50 without risk factors. So what are the other options? Now, it gets a little tricky here if you're also suffering from menopausal symptoms and you want to have some estrogen to help manage those symptoms. When you take estrogen and you still have a uterus, as you must if we're considering contraception, then in this situation, you would absolutely have to protect the lining of your uterus from the estrogen. So it turns out that too much of a good thing really isn't a good thing. Estrogen without progesterone puts you at risk of endometrial cancer or cancer of the lining of the uterus. So your uterus will need some progesterone to protect it from getting endometrial cancer. So if you're over 50 and you need both contraception and estrogen, there are really only two options, and they are both IUDs, intrauterine devices. You could have a non-hormonal IUD, so a copper IUD, and then have your standard MHT, estrogen progesterone combination. Or you could have estrogen and what is called a Mirena. A Mirena is a hormonal intrauterine device, meaning it releases a small amount of progesterone directly into the uterus. I am a huge fan of Mirenas. You would think that they paid me to get women to use them because I'm such a huge fan of them. I've had a couple myself. I've been putting them in for nearly 20 years for women, and I can honestly say that the overwhelming majority of women that I have fitted with a Mirena have been very happy with it. So what is a Mirena? It's a small plastic device. It looks kind of like a little anchor, and it has really fine, soft wires attached to it. This device is put into the uterus, and it just sits like right at the top of the uterus, and those little wires, which we refer to as strings, hang down into the vagina. The strings sit right up at the top of the vagina, so you usually don't even know they're there, and often they'll just kind of coil up and sit just inside the opening to the uterus called the cervix. So it's just kind of tucked up out of the way. Now, if you go online and you look for horror stories in regards to marinas, you're going to find them. And I don't doubt that they're out there. I have seen a couple of marinas go wrong in my time. But if you have one fitted by an experienced practitioner, the risks are really minimal. In the first few months of insertion, a woman will often experience some irregular bleeding. It's usually light and more annoying than anything else. And more often than not, it'll settle down in the first few months. I usually urge my patients to give it 6 months. Whatever bleeding pattern they have at 6 months is usually what they're going to get. They're a little bit more effort to have fitted, as only some GPs will fit them, but any GP can remove it. If you've had a baby vaginally, then it's usually pretty easy to have them fit. If you haven't, it's a little more tricky and it can be a little bit more uncomfortable, and some people might choose to have sedation in that case. In Australia, a woman who has a marina fitted at 45 years old or older can safely keep it in her uterus for 7 years, unless she's also using it for endometrial protection. So taking it as part of her menopause hormone treatment, then in that case, she would need to either have it replaced after 5 years, which is the normal time for a marina to be replaced, or consider another progesterone option if she's going to remain on menopause hormone therapy. Because the marina often gets rid of periods, it can be a little tricky to know when a woman is postmenopausal. For that reason, in Australia, we either recommend leaving it in until the woman's 55, or if she wants the option of removing it sooner, we can do 2 what we call FSH blood tests at least 6 weeks apart. And if the levels are high enough, it's recommended she leave it in still for another 12 months and then we can take it out. So the marina can be used with an estrogen as menopause hormone treatment. It can be used on its own just as a contraceptive. If you want menopause hormone treatment and you need contraception, then that's one option, or the other option is the copper IUD and then having your menopause hormone treatment aside from that. There's also a newer IUD called a Kylena. It's a little bit smaller than the Mirena. It still lasts as long as the Mirena. It lasts for 5 years. It's a lower dose of progesterone, but in Australia, it's not recommended that we use it over the age of 45, and it is not licensed for endometrial protection, so you can't use it as part of your menopause hormone treatment. Let's talk about a few other options for contraception. The Implanon is a contraceptive implant. Some people call it the bar. It's a little implant that goes into the arm. It's a progesterone-only method of contraception. It can be used beyond the age of 50. It lasts for 3 years. I'm not a huge fan, as it does make most women bleed pretty erratically, more often than not. The bleeding is usually just light and annoying, but a lot of women, in my experience, don't really like it. It can, however, also get rid of periods for some women, like the Mirena does. So the same rules apply in terms of when to remove it. Either replace it every 3 years until the woman is 55, or you can do the 2 FSH blood tests 6 weeks apart. And if the levels are high enough, use it for another year and then remove it. The Implanon is not licensed to provide endometrial protection, so it can't be used as part of the menopause hormone treatment. Another option is the depo-medroxyprogesterone acetate. So some people know this as Depo-Relevera or Depo-Provera here in Australia. It's DMPA for short. We don't tend to use this after the age of 45, and there's a couple of reasons for that. This type of contraception is associated with a small loss of bone density. It's usually regained after it's ceased, but it just makes us all a little nervous, I think. We're at risk of osteoporosis after menopause because of our estrogen levels declining anyway, and it just kind of seems counterintuitive giving someone something that we know is very likely going to affect their bones even if it's most likely going to be temporary. So after the age of 45, we tend to steer away from that one. It can also affect cholesterol and then theoretically increase our cardiovascular risk. In any event, it's an injection that's given every 3 months and it's not licensed for endometrial protection, so you cannot use it as part of your menopause hormone treatment anyway. Another option is the progesterone-only pill. The low-dose progesterone-only pills in Australia mainly work by thickening the cervical mucus, and they have what's called a 3-hour window. It has to be taken every day within 3 hours of the same time for it to actually work. So it can be a little bit fiddly. And again, it can cause some irregular bleeding or no bleeding. It's not recommended for endometrial protection either, so it can't be used as part of menopause hormone treatment. Other non-hormonal forms of contraception would include the male and female condoms or a diaphragm. Now, given our low fertility rate at this stage in our life, barrier methods are probably a reasonable option alone for contraception. Fertility awareness methods, so tracking the changes in your body temperature and cervical discharge, are a little bit harder at this stage when our cycles are all over the shop. So this method is thought to be less effective during perimenopause. So is the rhythm method. Trying to avoid intercourse during the mid-cycle is a lot more difficult when there ain't no rhythm anymore. The withdrawal method, or some people call it the pull and pray method, where the male partner removes the penis before he ejaculates so that hopefully none of it lands in the vagina, though some of it can come out before ejaculation occurs. So, though it's likely to be a lot more effective at this stage, it's still not recommended as an adequate form of contraception. So there you have it. You've got the skinny on contraception during this perimenopausal phase. I hope that I've answered some questions for you today. And as always, if this has been helpful for you and you can think of someone else it might be helpful for, please pass it on. And by reviewing and sharing the podcast, that will make it more visible for people who are also out there looking for this information. I am having so much fun doing these podcasts and all of the fun kind of marketing, I suppose, for it on social media. Absolutely loving it. If you haven't seen some of those reels, you might want to check them out because I've been having a lot of fun and I think that they can be quite entertaining. I'm getting some feedback to that respect. But today I'm going to ask you a favor, dear listener. It does look like word's getting out. I am just fascinated with the map and seeing where all the downloads are occurring around the world. It's so exciting and so fun and really just filling my heart with joy because this is what I want to do. I want to spread this message. I want to start this conversation. I want to increase awareness. I don't want the word menopause to be a shameful, taboo word like it has been in the past. I don't want other people like me being shocked and surprised at some of the things that were going on with my body that I really was not expecting. I want to get this information out there. So I'm going to ask a favor today. Dear listeners, please rate this podcast, write a review. Every time someone does that, it increases the visibility of the program for others to see. You can see that this is all completely free information. I'm not getting anything out of it other than the feeling of complete joy and contentment for doing something that I feel so passionate about. So I'm hoping you'll help me out. Thank you so much for the feedback that I've been getting. Please keep it coming. I really do want to make this the best that I can for you, and the only way that I can do that is by hearing from you and listening to you. So please feel free to share with me your feedback. I hope you have a great day, a great couple of weeks, and until then, I hope you opt to thrive. The Opt to Thrive podcast is designed for information purposes only and is not engaged in the giving of medical advice. The information provided on the podcast should not be used for diagnosing or treating a health problem or disease. In no way should the information provided by Opt to Thrive be considered medical advice, and at all times the advice of a medical professional should supersede recommendations from Opt to Thrive. If you have or suspect you may have a health problem, you should consult your healthcare provider. The views expressed in this podcast are purely that of Dr. Sims and do not in any way reflect those of the institutions she contracts her medical services to.
Thank you for listening to Opt to Thrive. If you've enjoyed listening, please rate and share the podcast. You can visit our website at opttothrive.com and leave a comment for any subjects you would like to hear more about.